So, WHO efforts to overcome these data gaps include the Global Burden of Disease Project, GBD for short, which since the year 2000 has published global, regional, and recently country estimates of injury deaths due to suicide, homicide, and war, as defined by the International Classification of Diseases. Global Burden of Disease Project is very important because it is a tool by which many international development agencies and governments set their priorities for the future. Global burden of disease estimates are typically projected forward to the next 10, 20, 30 years. For instance, currently there are projections until 2030, which interestingly suggests that by 2030, road traffic injuries will be the world's third leading cause of death overall, number 3. Very interesting. Of course, the global burden of disease is not without its problems, and there are many people that have got very sound criticisms of the global burden of disease methodology, and that's why it's being revised. I'll talk about that just now. GBD estimates involve, I think I skipped one here. No, I haven't. Yep. GBD estimates involve a very complex modeling procedure, which I'm not even able to go into. It should be Colin Mathers who's responsible for that work. But they involve bringing together data from vital and sample registration systems, data from surveys, from epidemiological studies, from conflict databases, from economic data sets, and putting these all together in a complex statistical procedure and actuarial procedure. You can find the methodology on the WHO website. For 2004, the latest year for which the GBD estimates are available, the distribution of violence-related deaths is shown here. You can see how most suicide deaths were concentrated in Southeast Asia and the Western Pacific, homicide in Africa and Latin America and the Caribbean, and war deaths in Africa and the Eastern Mediterranean. As I said earlier, what's important about GBD at this point is that it is currently being wholly revised using a big grant from the Gates Foundation, led by the Institute for Health Metrics in Seattle, Chris Murray and his group. And they are very, very attuned to the importance of bringing in new injury causes, new risk factors, and better understanding the impact of different types of violence as a risk factor for different health outcomes. So that's why at this point it's not possible for us at WHO to talk about the non-injury impacts of conflict, because we're busy. This group is busy working on precisely that issue. The revision started in 2007, and the aim is to have it complete by the end of this year. The revision will lead to new injury, disease, and risk factor estimates for the year 1990 and 2005, which will then become new baselines from which to project forward. It will be divided into 21 regions that span the global population. And hopefully it's going to produce a model and a template by which national burden of disease studies can be conducted. Some very good examples of such studies are the one in the Western Cape of South Africa, nationally in South Africa. They're using a burden of disease methodology basically as a serial surveillance tool. So they repeat the exercise every 6 to 12 months and understand how the burden of disease is responding to economic factors, demographic shifts, the influx of refugees from Zimbabwe. It's a really interesting project. Of course, in wealthy countries like Australia, this kind of methodology has been used with great effect to understand NCDs, non-communicable diseases, and the interrelationship between exposures to violence, alcohol use, smoking, obesity, depression, etc. So it's a very important methodology which, when modeled at the global level, can produce a method that you can apply at the local level. So, in terms of conflict deaths in particular, rather than going into the studies and rehashing what I'm sure is a very warm or heated debate between people in the different camps representing the different narratives that we heard about during the opening yesterday, I'm just going to say where the global burden of disease people stand in terms of some very key definitional issues. So, first of all, for GBD purposes, conflict deaths include deaths due to injuries that were incurred years earlier on the battlefield, that have only led to a death now. They also include recent deaths related to a conflict, or related to something, for instance, like unexploded ordnance that was laid down during a past conflict. So somebody blown up today in a war that occurred 10 years ago when that piece of ordnance was laid down will be attributed to that conflict. I'm not defending, I'm relaying these definitions. GBD estimates include deaths in military personnel and civilians, both on and off the battlefield. And GBD includes all organized conflicts, including cross-national, intranational events, and as a result of terrorism. So the 9/11 deaths would have been included as conflict deaths in the GBD thing, although I think in the US they put them as homicide deaths. I think it's going to be corrected, however. The GBD stuff does, however, exclude deaths from other causes, for instance, starvation and infectious disease that is indirectly due to collective violence. The input data for global burden of disease estimates of conflict deaths will be familiar to you. I don't think there's anything new to the people in this room who are far better versed in these issues than I. My last slide at this point. No, second last slide. WHO does participate in some of these very controversial efforts to measure conflict deaths through surveys, and for instance the Iraq Family Health Survey. This year, going to field is the Afghanistan Mortality Survey, and back in 2002-2003 the World Health Survey was conducted. I think what's important from this is that the method of choice that seems to be emerging from WHO and the partners working on this is to look at a sibling survival methodology as a means of estimating mortality in that population, because it creates, by going to a household, a far larger population denominator group on which to establish rates of death. So that seems to be the way that at least WHO and partners are going on methodology. So in conclusion, the WHO efforts to estimate global mortality due to violence suggest a number of recommendations for the way ahead. First off, there's no question that the ultimate goal has to be for all countries in the fullness of time to establish routine information systems that reliably register violence-related deaths and injuries. Improving the coverage and quality of such systems in Africa and Asia is really the huge priority. It's obviously going to take decades in many instances, but there can be no letter. Just as there is pressure to register births, there should be the same intensity of pressure to register deaths. Second, sample registration and demographic surveillance systems such as the one in South Africa have a critical role to play in settings that don't yet have the capacity to establish vital registration systems. So the work in Zambia, the work in Mozambique, using local mortuaries, has been very, very important in alerting the authorities to the proportion of road traffic injuries, stabbings, gunshots, whatever the case may be there, and getting them to pay attention to the importance of establishing such systems. Third, population surveys are likely to remain the instrument of choice for measuring violence in populations currently in conflict or shortly out of conflict, and we should therefore concentrate on improving the methods they employ and the quality of the data they produce. For more information, you can contact Colin Mathers or me, and you can go to, as I mentioned earlier, the WHO Burden of Disease and Statistical Information System websites. Thanks.